Hello everyone, this is Dr. Mahmoud, and in this lecture we're going to be talking about the Horner syndrome. We're going to know what is the Horner syndrome. We're going to talk about the hypothalamospinal tract, which when lesioned causes the Horner syndrome. And we're going to discuss all the findings of the Horner syndrome and why they happen. So if you like the content, don't forget to like and subscribe, and let's get started. So before we talk about the Horner syndrome, I want to quickly say a few words on the spinal cord dorsal column. As you can remember from our spinal cord anatomy lecture, we said that the spinal cord has a white matter composed of tracts and a central H-shaped or butterfly-shaped gray matter composed of ventral horns and dorsal horns. And we said that the ventral horns are responsible for motor innervation of muscles and are composed of alpha and gamma motor neurons, and the dorsal horns are responsible for sensations. Now we want to quickly know the names of the specific nerve fibers responsible for each dorsal horn sensation. So first, let's divide the dorsal horns into a medial side and a lateral side. The medial side contains heavily myelinated fibers, and the lateral side contains thinly myelinated or unmyelinated fibers. Myelin is a sheath covering the neuron axons and helps to speed up nerve conduction. We're going to talk about it in later lectures, but for now, know that the medial dorsal horn contains fast, heavily myelinated nerve fibers, and the lateral dorsal horn contains slow, thinly myelinated or unmyelinated nerve fibers. So let's start with the medial side. The medial dorsal horn contains nerve fibers that sense touch and proprioception. The nerve fibers that sense touch are named 2 and A beta. The nerve fibers that sense proprioception are named 1A and 1B. And as we said, all those nerve fibers are fast and heavily myelinated. On the lateral dorsal horn, we have slow, thinly myelinated nerve fibers that sense sharp pain and cold, and those are named 3 and A delta. And we have slow, unmyelinated fibers that sense dull pain and warmth, and those are named 4 and C. So to quickly recap, on the medial dorsal horn we have the nerve fibers that sense touch, named 2 and A beta, and the nerve fibers that sense proprioception, named 1A and 1B, and all those fibers are fast and heavily myelinated. And on the lateral dorsal horn we have the nerve fibers that sense sharp pain and cold, named 3 and A delta, and those are slow and thinly myelinated. And we have the nerve fibers that sense dull pain and warmth, named 4 and C, and those are slow and unmyelinated. So those are all the extras we have to know about the dorsal horns. Now let's get to the main topic of this lecture, the Horner syndrome. So first of all, we have a sympathetic tract in our body called the hypothalamospinal tract. And it's called that because it goes from the hypothalamus, which is a structure in the brain that we're going to talk about in later lectures, and descends to the spinal cord. So this tract is responsible for the elevation of the upper eyelid, for facial sweating, and for pupillary dilation or mydriasis. The pupil is the centermost black spot in our eyes that lets the light comes in. So this tract is responsible for the dilatation of the pupil, and Horner syndrome is simply a lesion in this sympathetic tract and will obviously present on the patient with the opposites of these actions. So the patient will have drooping of the eyelids, called ptosis, and will have a problem with facial sweating, called anhidrosis, and will have constriction of the pupils, called miosis. So the presentation of the Horner syndrome is shortened into the word PAM, P for ptosis, A for anhidrosis, and M for miosis. So this is basically the whole concept of this lecture. Now all we have to do is to talk about the hypothalamospinal tract and the types of lesions that can happen within the tract. The hypothalamospinal tract has 3 order neurons. It starts from the hypothalamus and gives off some descending hypothalamic fibers which serve as our first order neuron. The tract then descends through the spinal cord until it reaches the level of T1. After reaching the level of T1, it synapses on the lateral horn. If you can remember in the spinal cord anatomy lecture, we said that from the levels of T1 to L2, we have a lateral horn composed of preganglionic sympathetic neurons. So the hypothalamospinal tract synapses on that lateral horn at the level of T1. And this T1 lateral horn serves as our second order neuron. And from there, the tract ascends laterally, passing through the stellate ganglion at the T1 level, and finally synapsing on the superior cervical ganglion at the C2 level, parallel to the common carotid artery. And the superior cervical ganglion serves as our third and final order neuron. From the superior cervical ganglion, the tract ascends to the level of C4, and in that level we have the bifurcation of the common carotid artery into an internal carotid artery and an external carotid artery. Once the tract reaches the bifurcation, it splits into two. A part of it courses parallel to the internal carotid artery, and the other part courses parallel to the external carotid artery. The part of the tract that courses along the internal carotid artery ends up innervating two muscles in and around the eyes, the dilator pupilla muscle and the superior tarsal muscle, or the Muller muscle. The dilator pupilla muscle, from its name, dilates the pupil, causing what we call mydriasis, and the superior tarsal or Muller muscle helps maintain eyelid elevation. So that's the part of the tract that is parallel to the internal carotid artery. The other part that is parallel to the external carotid artery ends up innervating the facial sweat glands. So to quickly recap, the tract starts at the hypothalamus and sends descending hypothalamic fibers. Those fibers form the first order neuron. The tract then keeps descending along the spinal cord until it reaches the T1 level. Once it reaches the T1 level, it synapses on the lateral horn, then goes up laterally, passing the stellate ganglion at the T1 level until it reaches the superior cervical ganglion at the C2 level, parallel to the common carotid artery. The tract then goes up to the level of C4, where the common carotid artery bifurcates into the internal and external carotid arteries. Some fibers travel along the internal carotid artery and end up innervating the dilator pupilla muscle, causing pupillary dilatation or mydriasis, and the superior tarsal muscle or Muller muscle, maintaining eyelid elevation. The rest of the fibers travel along the external carotid artery and end up innervating the facial sweat glands. Now, as we said before, a lesion in this tract is called the Horner syndrome and will present with ptosis, or eyelid drooping, anhidrosis, or lack of sweating, and miosis, or pupillary constriction. And because this tract does not decussate or cross to the opposite side, a lesion in it always presents ipsilaterally. So the Horner syndrome is always ipsilateral. Now let's talk about some examples for lesions that may occur along the hypothalamospinal tract, causing the ipsilateral Horner syndrome. So, as we said, we have three order neurons. So a lesion can happen at the first order neuron, so anywhere between the hypothalamus and the T1 spinal level. Lesions that could happen here can be lesions in the brain below the hypothalamus, or lesions in the spinal cord above the T1 level. So there can be a lesion in the brainstem, such as a pontine hemorrhage or an ischemia or inadequate blood flow to the lateral medulla, causing the lateral medullary syndrome, which we will discuss in a future lecture. Or we can have a spinal cord lesion above the T1 level. Examples are Brown-Séquard syndrome, which is a lesion in half of the spinal cord due to a compressing tumor or trauma, for example, or a wide late-stage syringomyelia, which is a cystic dilatation of the spinal cord, and we briefly mentioned the syringomyelia in the anterior neural tube defect lecture, so you might want to check that out if you haven't. Normally, syringomyelia won't affect the hypothalamospinal tract, but if it's left untreated and reached an advanced stage, the spinal cord dilatation may be severe, causing compression on the tract and ultimately Horner syndrome. So, a lesion in the first order neuron includes pontine hemorrhages, lateral medullary syndrome, Brown-Séquard syndrome, or a late-stage syringomyelia. Now, a second-order neuron lesion can happen anywhere from the lateral horn of T1 to the superior cervical ganglion. An example of that is the Pancoast tumor, which is a rare form of lung cancer that occurs at the apex of the lung, possibly compressing the stellate ganglion and affecting the hypothalamospinal tract. And finally, a third-order neuron lesion is a lesion that happens anywhere from the superior cervical ganglion to the tract termination. Now, as we said before, the superior cervical ganglion is located parallel to the common carotid artery, which then branches off into the internal and external carotid arteries. So, an example of a third-order neuron lesion is an internal carotid artery dissection. We're going to talk in depth about dissections in cardio, but for now, know that an artery is composed of 3 layers. From inner to outer, they are the intima, media, and adventitia. So, if for some reason a tear happens in the intima, say for example due to hypertension, the blood in the lumen of the artery will pass through that intimal tear, creating an additional false lumen within the artery. And this condition is painful. And if it happens in the carotid arteries, it can compress the hypothalamospinal tract and cause Horner syndrome. So, to quickly recap, a first-order neuron lesion in the hypothalamospinal tract can occur anywhere from the hypothalamus to the T1 level of the spinal cord. Examples are pontine hemorrhages, lateral medullary syndrome, and any spinal cord lesion above T1, such as Brown-Séquard syndrome and late-stage syringomyelia. A second-order neuron lesion can occur anywhere from the lateral horn of T1 to the superior cervical ganglion. An example is the Pancoast tumor, which is a lung cancer that occurs at the apex of the lungs and can compress the stellate ganglion. And finally, a third-order neuron lesion can occur anywhere from the superior cervical ganglion to the tract termination. An example is a carotid dissection, which is painful and can compress the hypothalamospinal tract, causing Horner syndrome. So that was all we had to know regarding the Horner syndrome. I hope it was nice and easy. If you have any questions, don't forget to leave them in the comment section, and I'll see you in the next lecture.